Welcome to the CCO World CCO Lifestyles webinar with Dr. Antonino Secchi. My name is Jean Morrison with GC Orthodontics, and it's my pleasure to introduce Dr. Secchi and the course tonight, Mastering Class 2 Treatment from Accurate Diagnosis to Effective Mechanics. Dr. Secchi maintains a private practice in Devon, Pennsylvania. He has a certificate in orthodontics, a Master of Science in Oral Biology from the University of Pennsylvania. He is a diplomat of the American Board of Orthodontics and a member of the Edward Angle Society of Orthodontics. He is published in various dental and orthodontic peer-reviewed journals in the area of treatment mechanics and straight wire appliance. He wrote the chapter Contemporary Mechanics using this straight wire appliance for the last 3 editions of the Graeber, Van Arsdale, and Vig orthodontic textbook. He is the founder of the Complete Clinical Orthodontic System, CCO, and had provided continued education for orthodontists in the United States as well as throughout the world. He loves to spend time with his wife and 5 children and has a passion for photography and mountain biking. In this webinar, you will learn how to accurately diagnose different types of Class 2 malocclusions, effective treatment mechanics for more efficient and effective results, and practical experience-based insights to apply in your practice. As with previous webinars, Dr. Secchi brings a unique, balanced perspective that integrates both professional mastery and personal well-being. Because your best work begins when your life feels balanced, and that's the power of living the CCO way. Without further delay, I give you Dr. Secchi.
Hello, everyone. First of all, thank you very much for taking the time to attend this presentation. This is the second webinar in this series of webinars that we are trying to put together this year. I wanted to remind you that they are recorded. So if you want to go to see the first one, when I explain more about the details of the CCO system and mechanics, you're welcome to do it. But today, I'm very, very happy to talk about something that is always a question. How do you treat class 2s? And I would like to emphasize the diagnosis, and of course, we're gonna see cases, and I'm gonna tell you what do I do with the mechanics. But how many times people come and ask me, how do you treat class 2 malocclusions? What's that silver bullet that you see everywhere that people are talking about this appliance or the other appliance? What is that magical thing that people do that works for everything? And when they ask me that, I already know that there is a problem. Because, of course, not all the malocclusions class 2 are the same. And you cannot treat all the same. So take a look at the following cases, if you will. Look at these 3 cases. They're all different. They all can be considered class 2s. But you're just seeing, first of all, the teeth. And we need to know more. Let's see the next 3 cases. Same situation. They all can be considered class 2 cases. Some of them can be mixed dentition, some of them can be adults. What about these next 2 cases? So I put here 8 cases that we will review later and see how I treated them. So my question is, would you treat all these cases the same way, with the same appliance, with the same protocols? What else do you need to know to decide how to treat them? They're all extractions, non-extractions, functional appliances. I mean, how do you treat this? Surgery? So, of course, we need to know more. So what about, of course, we need to know the face. The face is very important. We all know that. But also when we talk about class 2s, sagittal, we need to understand very well the mandible. We need to understand the potential for the mandible to grow and the direction of growth. When growth is there, of course, you have adults, there's no growth. But understanding the mandible in that adult plus other things can help you to decide what's the best treatment. So very interesting. And we will review these more in details. So class 2, what are we treating? What do you want to correct? It is an increased overjet. It is the class 2 molar relationship. Is a retrognathic mandible. Is a prognathic maxilla the problem? Or a little bit of everything? It is a dental problem, skeletal, or both. And it's very interesting because, I mean, we've been doing this for over 120 years, and we still have the same questions and the same problems, and people are looking for the same kind of magical solutions. So, what's going on? So, unfortunately, you can see problems uh, in the publications. I mean, let's see this one that I mean, we can be talking about all day here about publications, but this one caught my attention because it's recently, 2018, is a Cochrane database review, and it's all basically based on prominent upper front teeth. So if you are going to do a research on prominent upper teeth for malocclusion for class 2s, you already start in the wrong foot, because not all the prominent teeth, or in other words, prominent teeth doesn't tell you the severity of the problem. Not even the class molar relationship is telling you the severity of the problem. Therefore, some prominent front teeth can be treated very easily, and some others can be much more complicated. So let me show you, of course, what is under the face, which is the skull, and some of the cephalometrics that we use for diagnosis, and some of the controversies that you will find that I know many people find the same problems. So watch this. Same overjet. You can see these two segments of a cephalometrics, they have the same overjet. In fact, if I show you a little bit more, they have the same A and B, or very similar. But if you see the whole thing, you will realize that we're talking about completely two different subjects, completely two different patterns, and completely two different responses to any treatment that you will do in these cases. You cannot treat the right subject the same as the left, or vice versa. However, if the only thing that you look is from the A and B to classify the severity of the class 2, or the only thing that you see to classify the severity is how much overjet they have, over 6 millimeter or whatever, then we are not really on the right track. And that is what's been happening over the last 100 years. And that's why people they see a lot of controversy, because some appliances work really well in some subjects, but not in others, even though they might have the same overjet. Some appliances work really well in some cephalometric patterns with the same A and B, but they're completely different cases. So we need to know more about that. Of course, there is a lot of cephalometric problems that we see. It's a lot of variability in the Frankfurt plane. There's a lot of variability in the SNA plane. And of course, those are intracranial planes that many cephalometric analyses use, and has nothing to do with how you see the face of the subject or how you see the chin projection. Nothing to do with it. Also, Arnett in 2004, 20 years ago, put together this paper published in the AJODO, where he put two identical cephalometric analyses. The only difference is the cranial base angulation. And you can see that one based on A and B is a maxillary protrusion, or the SNA, SNB. The other one is a mandibular protrusion. So how can you understand that? So depending on what analysis I use is how I see the severity of the case. And it's because of the same, the variability or the intracranial landmarks that we use. Also, I want to point out that angular measurements, they lose the validity in vertical cases. Just think about an angle. An angle, the longer it is, the more divergent it is. So the distances between the two sides of that angle diverge. Same angle. So if you can see in this particular case, the ceph in the upper and in the lower, of course, the chin projection is way worse in the one below because of the vertical problem, although they have the same A and B, same angle. So we need to understand these things to evaluate really the severity of the cases. So what I typically use, and I done this for the last 30 years that I've been doing this pretty much, is 25, 26 years, is using a different analysis that I wanted to show you. If you know it, great. If you use it, great. So I want you to know about the Bjork-Jarabak, because Bjork-Jarabak is telling you all about the mandible relationship to the skull, and also some ratios that you need to understand. And also, those ratios are very important to predict the growth of the mandible, to see the potential of growth, and also some angles that they will show you the direction of the mandible. We can talk a lot about this. Because of the small time that we have, I just wanted to bring here just some few, I could say, markers. Let's talk about this one here. The relationship between the base of the mandible, the mandibular base, with the anterior cranial base. Typically, 11 years old and older is 1:1, as you can see in this particular case. If I have the mandible 10 millimeters shorter than the anterior cranial base, I'm in trouble. And no matter what you use, no matter what appliance, no matter what functional, no matter what you use, you're not going to be able to solve that case. Now, what about the ramus? The ramus needs to be a relationship of 3 to 4 with the posterior cranial base. So that is telling you pretty much that is the ramus of the mandible is very short, approaching 1:1 ratio to the posterior cranial base. That is a bad grower. It's the typical growers that they grow vertically. So every millimeter of grow will go down, not forward. So these two are very important to analyze the phases of growing patients. What about the saddle angle? Also important, because sometimes you have people with the saddle angle very open, and the more open it is, the mandible sits back, can be very long, but it sits back. You see that in a lot of brachycephalic, sometimes class 2 division 2s. What about, or the opposite? If you have a case with a very close saddle angle and a very, very large mandibular body, and the subject is very, very young, you know that the potential for a big class 3 is there. And there's nothing you can do. Just watch. So what about also the lower gonial angle? The lower gonial angle for me is very important, because that angle is telling me how the mandible is growing, if it's growing vertically or if it's growing more horizontal. Of course, there are many other numbers, many other ceph that can do this, but I found this very simple. Everything that I need is in one ceph, and I use this pretty much in every case. Of course, after so many years, right now, to be very honest with you, I don't really need to trace every single ceph. Pretty much the patient walks into my office and I know pretty much how the face look. I look inside and I know a lot of things because I've been doing this for so long. But if you haven't, or you still have questions about what is the potential of that class 2 that I have in my chair here, that kit, I I suggest you to look into this, because it will help you a lot. See how much information you have here in these 2 minutes that we've been talking about it, compared to if you just do a, let's say, a Steiner or any other simple analysis where you have nothing about the mandible. So the A and B cannot be, the A and B actually, you don't even have to use it anymore. So very important is to understand the potential of the mandible to grow and the direction to see if that class 2 that you see, those overjet, those class 2 molars are going to respond very favorably for your treatment. Can be a simple case with just some mechanics, class 2 elastics, or if we're talking about a more involved case. So let's see some few cases. We can talk about the strategies that we use for the mechanics. So this 12-year-old kid, the first thing that you see in the face, to me, is more brachycephalic. And when we see the face, you need to see also that sometimes the soft tissues mask some of the features of the face. So that's why you need to see the intraoral, you need to see the face, and you need to also see the ceph. So definitely brachycephalic, good chin. You see the intraoral views is a class 2 with a big overjet. And however, another thing that I look intraorally is the curvus P. Every time that you have a deep curvus P, you have a huge potential to correct or fully or partially the class 2 by leveling the occlusal plane. If this kid has a completely level curvus P and 6 millimeters of overjet, it's a completely different case, as we will see later when we do the mechanics. So you see this class 2, and you see now the ceph, very proclined teeth in the upper jaw, class 2 molars. You see the ratio of the mandibular body and the anterior cranial base is 1 to 1. Great mandible. Posterior cranial base 32. Ramus height 47. Great ratio. Lower gonial angle 60 is close. So every millimeter of growth will go forward. So this case is pretty much, to me, honestly, is a class 1 pattern with a class 2 malocclusion. Easy case basically to treat just with routine orthodontic treatment. So what I did in this case, I level and align, and I will tell you to refer to the webinar number 1 when we explain the wire sequence of the CCO system and why we do what we do with the wires and the mechanics, arch coordination, etc. But here I'm just gonna kind of fly on the mechanics. We put the upper and lower braces. You will see something that I do in some of these class 2 cases. I leave some space between the premolars without braces to put some coils and class 2 elastics to sometimes distalize maybe 1 or 2 millimeters the molars if I can to improve the correction of the class 2. So level and align with a no 140 initial alloy wire. We moved to a 2020 bioactive wire as part of the mechanics just to finish the leveling and aligning. And then we go to the 19 by 25 stainless steel. After one visit with the coordinated 19 by 25 stainless steels in the mouth, I removed the lower wire. I put a reverse curve in the wire to help leveling the occlusal plane. And in this particular case, I place a night-tie coils between the canines and the molars. I don't typically do it between the canines and the molars. I typically do it, as you will see later, between the 4 and the 6. Basically, I leave only one tooth without bracket, which is typically the 5, just to be able to squeeze the coil in. So watch the potential of leveling the curvus P in this particular case. This is with the stainless steel with the curvus P not corrected, and now is the curvus P corrected. So we level the occlusal plane with the stainless steel. At the same time, those coils are acting, and we're using class 2 elastics. Once I am happy with the molar relationship, the canine relationship, there's some spaces there, everything is level. It becomes a different case. Easy, remove the coils, power chains, class 2 more in one side than in the other. You can see here the case from the occlusal view with some little spaces in between the premolars after the coils. So we close all the spaces with power chain. Basically, want to bring you to the end of it. We finished the case successfully. 2 years post treatment. And of course, you can see here the face. He grew as he had to grow. We knew that. Good chin, horizontally, perfect. No problems. So you can see the ceph before and after. And if you like to trace the ceph, this is the tracing. I did that for more than 10 years of my career. I trace every single patient and actually before and after, and I superimpose everyone to learn how the teeth move with the mechanics that I was doing. It's a learning experience that I suggest you guys to do it. If you haven't done it, it's never late. So do the homework, and then the more you do it, the more you can then you will just know it for most of the cases. So you can see another case here, 11-year-old. This is a phase one case, completely different. It's a class two and on with crowding, and specifically it is migrated forward because of the lack of space for that incisor that came ectopically. So of course, when we see this case, it is a class two, a little bit on the vertical side. You have a lower gonial angle of 81. That is a little bit high. Everything 80 or bigger, we're in the high angle territory. Careful with these cases. Mandibular bite is not bad. Is good. Ramos high is not good. Is almost 1 to 1. So these are the cases that you want to avoid any extrusive mechanic. Any mechanic that you feel is going to upright the molars too much or extrude them is not good. This is the case that if you are planning to do a functional appliance, forget about it. I mean, with that angle and then Ramos height, most likely is not gonna work. So this girl, I did first what I needed to do, which is correct the transverse dimension. So we put an expander, and we expand the upper jaw because it was narrow, which is another thing that I didn't bring all the literature, but it's there for years and years. It says that most of the class 2 cases, specifically class 2 division 1 cases, are narrow in the upper jaw. So don't wait until you correct the sagittal to correct the transverse. We know that the transverse should be first. So we correct the transverse, we coordinate the arch skeletally, and then basically I did some few braces. You can call it like a 2x4, something like that, just to align the front teeth because that was the main problem that she had, and then just wait for the phase two. So we put some braces on the premolar, the incisor with the CCO. It's not a big deal. We put an 014 and we have some space. And in 8 weeks, those teeth come like this, completely aligned, super good. And then we put a 2020 to finish this phase. And she was delighted, of course, with the teeth kind of all aligned, no problems. And you can see the beginning at the end of this kind of little phase one that we did. And then we just waited for the other teeth to come. And we just start the phase two, basically full braces. I'm not going to review the wire by wire, but we went to the 19 by 25 stainless steel with some rubber band, short elastics. Remember that we're talking about a case that is more high angle, so you need to be very careful. Don't do long elastics on flexible wires. Don't do long elastics on stainless steel round wires if you do it. So I do all my rubber bands on 19 by 25 stainless steels, and in these particular cases, as you can see, I prefer definitely a short class 2 elastics. So they have a vertical component in the middle of the face, not in the back. So it helped me to level the occlusal plane, and it doesn't have an extrusive component with those wires that they're holding those teeth there. So we put the final wires and vertical elastic in the front port to settle the occlusion, and we finish the case. As you can see here, um, that is also 2 year post-treatment, and that's how our patient looks after treatment. That's the Ceph before and after. You can see obviously there was a compensation of the upper incisors. You can see clearly, um, and the lowers as well. The case is still same vertical condition. That hasn't changed. In fact, you can see that we were able to maintain the axis of the patient, which is kind of what you want in these cases. You don't want to open it. You want to maintain that. That's why I was kind of emphasizing be careful with the extrusive mechanics. What about this kid? A 13-year-old, a little bit retrusive mandible, but also a case that is a full class 2. You can see with crowding, of course, but also has a deep curvus P, which is in our favor. So deep curvus P, crowding, the pattern is not great, but it's not that bad. Is a class 2, mild class 2 skeletally to my taste. The mandible is not that smaller compared to the anterior cranial base. The ramus is not huge, but it's not that small. The lower gonal angle is 73, is kind of normal. So I mean, it's not a great pattern, but it's a pattern that we decided to camouflage. So this case I treated also with braces, leveling and aligning, 014, 2020. We put the braces in the lower arch. After that, we level the lower arch until we get to a 19 by 25 stainless steel, upper and lower. On the stainless steel, I put a little bit of reverse curve and class 2 elastics from the upper canine to the lower second premolar, and you will see the effect of the reverse curve. Of course, time is not from one appointment to another. What you will see here, it doesn't happen in 6 weeks. So this is the mid of the case. We're working on the working stage, making sure that kid wear the elastics, and that's all that, and always paying attention to the relationship of the arches, the arch coordination, closing the spaces with power chain, and you can see the effect of the reverse curve on the case. And then at the very end, I engage the second molars with a flexible wire just to finish them in a better position. Be very careful engaging in this kind of a vertical cases, second molars too early. I prefer just to let them come by themselves, and if I need to fine tune their positions in these particular cases, vertical cases, I put those tubes at the very end just to align them better, but without having the risk of extruding them as I level them, because it's not really nice in these particular cases. And we took the braces off. You can see this is the before and the after here. Small teeth, I mean, but it is what it is. And we treated the case successfully. That's the before and the after cephalometrics. We can trace them. We can superimpose them. We can be talking about this a lot. So it was a camouflage. There's no question about it, but it's a camouflage, and sometimes we need to do it. So what about this case? This is another girl that can be your patient tomorrow in the office. Comes with a little bit of a retrusive chin, however, a good growth potential. Just by looking at the face, I know that she's fine. She's brachycephalic, square face, or every millimeter of growth is gonna go forward, no, not that downward. So You can see the intraoral view, the typical class 2 division 1, and the 5 were just coming in the upper jaw. You can see there, and I decided to treat her also with the mechanics and the coils. So use kind of a combination of leveling the occlusal plane, coordinating the arches, and a little bit of distalization. So I start by leveling the upper arch with an 014 initial eye. I went to a 2020 bioactive in the upper, and I bond the lower arch with a 014 initial eye. I brought the upper and the lower to a 2020, and people ask me sometimes, do you do rubber bands on the flexible wires, the 2020 bioactive? I said, you know what, typically not, but sometimes yes. I mean, you never say 100% yes or not. So sometimes yes, and this is a case where I would do it. The alignment is pretty good, and she's a brachycephalic, so I'm not worried about any kind of vertical problems. So, and I'm using a 2.5 ounces 516 rubber band. So it's not like a super tight rubber band. It's 2.5 ounces, 2.7, 2.5, 516. So it's kind of light, and I kind of put it in the upper canine to the lower second premolar. And then the next appointment, I'm gonna do the 19 by 25. I start consolidating the upper arch from premolar to premolar with a power chain. I leave the 19 by 25 stainless steel coordinated in the mouth for one visit. And when she comes back, I put a reverse curve in the wire in the lower, and I put the coils. So you see over there, she comes back. I put the reverse curve in the wire. I put the coils and class 2 elastics. This time, I change the elastic for 316 4 ounces. A little bit smaller, a little bit tighter. Canine, upper canine to lower second premolar. And you can see also the canine relationship right now. And you can see them right now. So she did the homework. She wore the rubber bands. The coils, they moved the molars back a little bit. You can see the spaces now that I removed the coils in between the premolars. And then I start consolidating the spaces. You see how the bite kind of opened um, with the reverse curve. You can see more expression of the reverse curve, and now I'm just settling the case with triangular elastics, also 4 ounces, 316. So I had the spaces closed, the settling elastics, the power chain to consolidate the spaces, the arches are coordinated, the occlusal planes are level. So all the goals that we have for our protocols in stage number 2. Then we take the braces off, and you can see this case. So you can see the face, of course, the mandible grew horizontally, it's much more harmonious, and that was basically this particular case. Now, what about this case? I have a lot of these cases. I just brought one that is very good for teaching. But we all have these cases every single day, no? It's the typical class 2, division 2, can be more severe, less severe, etc. But they're all kind of the same pattern. They all kind of people with square faces, brachycephalics, retrocline teeth, and a deep curvous P, where conventionally people start talking about intrusion. Oh, we need to intrude the upper teeth, it's a deep bite. We need to intrude the lower teeth, it's a deep bite. Back in the days, decades ago, people used to do a utility arch a la rickets to intrude the anterior teeth, because of course you have in the lower jaw 2 occlusal planes, as you will see later. So you have an occlusal plane in the back, an occlusal plane in the front. So all of the mechanics, while the most important part of this case is not what teeth you will intrude, is basically just level and aligning and correct the inclination of those teeth. That is what people forget, and I will explain you that with some diagrams very, very carefully here. So look at the Ceph. It's a square. So it's a little cube, the face, retrocline teeth, and we need to procline them to obtain the normal inclination. And let me put this as an example. If you follow the occlusal plane from the molar tube to the incisors, in this particular case, you will know that the lower is extruded, the upper is extruded. So the red line that you see there is not coincident with the bracket, with the slot of the bracket. So without intruding those teeth, what I'm going to do with leveling is exactly that, level and procline them to the normal proclination, and now everything is coincident. You have now the red lines that they go to the tube, to the bracket, and you have those teeth with the right inclination, torque. In our system, we use plus 12 degree for the incisors, minus 6 for the lowers, plus 12 for the upper. But that is the rationale. Don't intrude teeth that they're not in the right inclination. First, incline them correctly and then see what happens. And that is very important, because beside that, when you do this inclination, you are increasing the arch perimeter, and that leaves you room for sometimes crowding. So it's very important. And also don't forget that you cannot level the lower arch if you don't have the upper arch level first with the right proclination of the incisors, with the right torque, because then the lowers cannot unravel. So that's why these cases specifically, I always start with the upper arch first. Andrew said it very well back in 1988. If you have a wrong inclination of the incisors and you bring that class 2 to a class 1 in the back, you will end up with a space in between the premolars and the canines unless you procline the incisors. The incisors, when they procline the right way, optimal torque, they use more arch perimeter than if they are completely upright. Okay, so don't forget about that. Don't forget about all the knowledge that we have from the 70s. Andrew said it clearly. For 1 degree, for 4 degree of buccal crown torque for the incisors, you get 1 degree of mesial tip. So that's why you use more arch perimeter when the teeth are in the right inclination in this particular class 2 div 2 cases. So basically, you have a deep curve speed, increased overbite, overjet, usually long angle cases, usually good symphysis, and you are going to level them with class 2 elastics and reverse curve speed. You are going to level these cases. So level the occlusal plane, meaning the lower jaw level the curve speed. Lower incisors are allowed to procline in these cases, no problem, and improve torque of the upper incisors. I typically use these rubber bands. I could say 80% or 90% of the cases. I use the medium, which called here the 4 ounces, 316. I typically use those rubber bands with 19 by 25 stainless steels, class 2, class 3, triangular. In some few cases that with a good pattern, and I need to start earlier on the rubber bands, I typically start in the 2020 bioactive with some light rubber bands, 2.5 ounces, 8 millimeters, as you can see there, the 516. And in some cases, like some heavier patterns, brachycephalic, kind of for more kind of for muscular jaws, I use a heavy 6 ounces, 316, not very typically, but those are the elastic that I use. So let's do this case wire by wire. So this deep bite case, I start with an 014 initially, leveling and aligning. You can see I went from that wire to a 2020 bioactive. See how much change. Now I have an overjet. That overjet allowed me to now unravel the lower arch. So I start the lower arch with an 014 initially. I open the bite in the back so patient doesn't bite the braces. I level the lower arch until I get to a 19 by 25 stainless steel with the upper. I coordinate the arches like this, upper and lower 19 by 25 stainless steel, one visit. Second visit, I take the wire in the lower jaw, I put a reverse curve in the wire, stainless steel 19 by 25, I put the wire back, short class 2 elastics, and watch in a couple of visits, you will have the occlusal plane completely level. And now you have all of those brackets in one plane in the upper and in the lower, and the class 2 elastic, proper inclination of the lower in the upper. I remove the stops in the back so the molars settle, and basically finish the case, close the spaces, and we finish the case. You can see here, 1 year post-treatment. You can see same pattern, same facial pattern, nice smile. You can see the ceph before and after, how the inclination of the incisors change. What about this case? This case as another kid with class 2, another class 1 pattern with a class 2 malocclusion, block-out teeth. In this case, I didn't want to have any trouble. You can do a lot of things. I didn't want to kind of open the body more. I decided to treat it with extractions. I said I'm going to remove the upper 4, lower 5, um, and then treat him as an extraction case. So we start with a 014, as you can see there, initially. Then I'm just gonna move to a 2020, 19 by 25, close the spaces. I'm not gonna spend time in the mechanics. We're gonna go straight to the last arch wire. Well, actually 2020 in the upper and the lower. You can see how it changed. What is impressive about this case, as you can see, is how you go from here with that wire to here without any proclination of the incisors. The canine went just all the way back to the space. Then 19 by 25, close the space, put the final arch wires to settle the buccal segments, and we finish the case. As you can see there, so that was a class 2 molar relationship and canine, but it was in a class 1 pattern. So that's a case finish. And you can see here the initial. You can see it's a class 1 pattern, extremely nice mandible. I would argue that it might look more like a class 3 than a class 2, but with a class 2 malocclusion. So when they tell me how you treat class 2, it all depends. Many factors. So and see the inclination of the upper incisors and the lowers remain exactly the same in this case. 120 initially, 119 post-treatment, 87 initially the lower incisor to the mandibular plane, 88. So they didn't move. It was all the movement happened in the buccal segment, which is what we wanted it. So what about this case? This one is almost the last one, guys. So it's definitely a convex face, very retrusive mandible from the facial standpoint. She got treatment before, and I was like the third opinion. So 11 years old, not very happy with the results. So I told them, listen, I mean, the problem here is that we are, this is beyond what we can do just with braces. I don't want to be the third orthodontist throwing this magical different appliance that is going to bring the mandible forward. I don't want to bring the upper teeth back because actually the nasolabial angle is not great. So what she really needs is the mandible to go forward. But unfortunately, I don't have any appliances that can bring it forward and keep it there stable. So they understood very well. It was a deficient maxilla. So I told them right now you're too young, but we can expand the upper jaw. We can level the upper teeth. And so you can have a nice smile. And we can put a retainer. I put an Igor. and we will see you back when you are older, and we're gonna bring the mandible forward surgically. They understood very well, they agree, and we did that. So she came back here years later, and I treated, I mean, with braces and a BSO. We advanced the mandible, and then they got the result that they wanted, and they're all happy. So sometimes you just need to explain things, and don't trying to to do to camouflage cases that they're beyond what you can do. So what about this particular case? I want to finish with this case. A 59-year-old lady comes to me with the diagnosis of mild to moderate sleep apnea. She actually is working in the medical field, so she knew that that was not good. And of course, I told her, listen, I mean, that's another nail in the coffin that you have a class two, the mandible is back, you have all this, and beside that, you have kind of a sleep apnea. So ideally, I would like to treat you surgically. She agreed with it. So I could have removed upper bicuspid. I could have just camouflage and leave her in class two, which is nothing wrong with it, to be very honest with you, and put a retainer. That's fine. How many people are walking in the world with class twos and they live super happy? So, but she wanted to have a change in her bite and also the airway and everything. So, my duty here was to decompensate this case. So I did a little analysis. What I realized that if I put those teeth where they should be, and I move the lower jaw forward to look good, I'm gonna need about 5.5 millimeters advancement. Therefore, I need 5.5, let's say 6 millimeters of overjet, so the surgeon can advance the mandible. So we did that, not very difficult. We aligned the upper teeth with braces, and we aligned the lower teeth. When we got to the stainless steel coordinated arch wires, I ran class 3 elastics, class 3. So to increase the overjet, to bring the incisors back, upright them, and when we got the 6 millimeters of overjet, she's ready for the procedure. She had the procedure done. She came back. That's 10 weeks after surgery when I removed all the logs and I put new wires. And then it was just about to finish the case, some details and tricks here and there. And we took the braces off. That's 1 year post treatment. And that's the result of the patient. So remember, she was like this, and now she's like that. So that was a big change, not only in the face, the airways, everything. So I would like to finish with this. It's fascinating when you start digging into a specific problem, and we are just kind of talking about the tip of the iceberg here, but I wanted to dig in more into the diagnosis, because class 2 malocclusion is too unspecific. So you can ask, how do you treat class 2s? Because there's so many different aspects of it. We need a better definition, diagnosis of the problem to solve it with more consistency. There's no question about it. So the next time that somebody is telling you, this is how I treat all the class twos, make sure that you understand what they're saying, because I don't think you can treat all the class twos the same way. Overjet and A and B, not great indicators of class 2 complexity. Important is to evaluate the mandible growth, potential, and direction. Transverse discrepancies are commonly found in class 2 malocclusions, so be aware of that. And camouflage is okay as long as facial aesthetic and airways are not compromised. So basically, in these 45 minutes, I wanted to run by you this. So thank you very much. And let me see, I might have some questions here. Um, so if there's any question, you let me know. I'll be more than happy to answer them. So one question is, did you do curve speed leveling only with reverse curve? Which wire size and how many mounts you need to level? So yes, I mean I don't use wires with a pre-curve that you can find typically flexible wires, night-tie wires with pre-curve. I actually put myself the curve of speed on the stainless steel wire, 19 by 25 stainless steel. I put a reverse curve with my fingers and I coordinate the arch wire very well. Typically, depending on the case, can be a minor problem. You can wait 8 weeks and you can see the effect of it. Or you can sometimes wait 2 appointments. Typically, I see people every 8 weeks. So let's say you can wait maybe 2 appointments, like a 4 months to 5 months to see an effect on a more severe case, but you will see it. What side wire do you consolidate anterior spacings? Yeah, that's a good question. So typically, if I have a patient very demanding that you level and align with the first wire, and then there's some little spaces, and I put a 2020 bioactive, and the patient is like, oh, why I have these spaces here? I start closing them right away with a power chain on a wire that is as flexible as the 2020 bioactive. Now, in those cases, I tell the girls put a loose power chain. So when I say put a loose power chain, let's say on a 2020 bioactive, I put they just grab the power chain, they stretch it a little bit to make it loose, and they put the power chain on the 2020. But generally, I run the power chain and I consolidate the anterior spaces on a 19 by 25 stainless steel. In that wire, you can run power chain or power thread if you need, without losing the torque of the incisors and without losing the arch form. Yeah, so I mean, and again, I mean, this is gonna be recorded, so I'm pretty sure people will see it. And if there's any other question, I'm available. You guys can write me an email or through GC um, if you have any questions. It's not a problem. So I would say just to finish, thank you very much, and I'm looking forward another one. Maybe next time it can be another topic of interest. There's so much that we can talk about orthodontics from maybe class 3, which is kind of for fascinating topics too, or open bite, etc. So I'm looking forward to be with another webinar soon. And thank you everyone for your attention. Thank you, and have a great rest of the day or good night.